Well, good morning, ladies and gentlemen. I'm here to talk today on the 24-year breast cancer mortality decline and mammographic screening versus adjuvant endocrine and chemotherapy in the state of Victoria, Australia. This is the culmination of 15 years work by my group on mammographic screening evaluation and follows on my training as a cancer epidemiologist at the International Agency for Research on Cancer in 1992 and 1993. I have superimposed Western Europe here on Australia to give you an idea of the vast distances involved. It's the 6th largest inhabited nation. It easily encompasses all of Western Europe. The United Kingdom here fits 3 times into my state of Victoria, and all of Australia is closer to the equator than France, except for Hobart. Now, the states of Australia are shown here. This is Victoria, from which this data comes, the capital city of Melbourne, and the adjacent state of New South Wales. In 2019, 57% of the 12.8 million female residents of Australia, there's only about 25 million residents in a country the size of Western Europe, 57% lived in New South Wales or Victoria, and that was 32% in New South Wales and 25% in the adjacent state of Victoria. Australia is highly urbanised, with most citizens living in the 6 major capital cities. 4.9 million live in Melbourne, and 4.7 million live in Melbourne, and 4.9 million live in Sydney. Canberra is our capital. Breast cancer is a very heterogeneous cancer. The genetic backgrounds of different populations differ, and as you heard from the last speaker, single gene differences can make a great difference. Every mammography screening program will potentially have a different sensitivity for detecting cancers, and treatment effectiveness of breast cancer will differ between populations according to ethnicity, access, compliances, drugs, availability, and follow-up. Therefore, each population-based mammographic screening program should be considered to be unique. The breast cancer screening monograph from IARC from 2016 identified that about 2 billion women globally have exposure to mammographic screening, and 57 have data on follow-up. However, only 5 of these programs measure the stage at diagnosis. So, breast cancer is complex. Many rapidly growing cancers, such as cancers D here, will progress from undetectable to incurable within the screening interval. Here are the screening intervals. And so their early detection can make little or no difference to the fate of the patient. Screening aims to detect slower growing, potentially fatal cancers, such as tumour C here, that will be detectable with screening and treatable early when they are more curable. Tumour C. Other cancers are so slowly growing, such as tumours B and tumours A, that they may never be detected clinically and may only be detected by screening, and their diagnosis and treatment will have no benefits, but only harms for patients so diagnosed. Population-based mammographic screening commenced in Australia in 1992 as a free service offered to all asymptomatic women, that's women with no breast symptoms, over the age of 40 years. It's delivered via the 6 state and 2 territory governments, and the program is called Breast Screen. Screening is performed for targeted women aged 50 to 69 years, and this was extended to 74 years in 2014. They're individually contacted every 2 years for repeat screening, and these programs were therefore named Breast Screen Victoria, Breast Screen New South Wales, etc. There are two prerequisites for screening to directly reduce breast cancer deaths, or in this, as it happens, for any kind of cancer screening. First, the screening must advance the time of diagnosis of cancers that are destined to cause death. And secondly, early treatment of these cancers must confer some advantage over treatment of clinical diagnosis. This is taken from Blair and Welsh, New England Journal article in 2012. So screening this is how screening directly reduces breast cancer mortality. It can also indirectly reduce breast cancer mortality by stimulating and facilitating a general improvement in breast cancer management. However, evidence from the 1999 Victorian Breast Cancer Treatment Survey indicates that this was not the case for that year in Victoria. Participation in Breast Screen Victoria. This shows participation from 1994 to 2011. The program only began in 92, and you can see that participation was very low then. It rapidly rose to a plateau of about 50 to 60% of women aged 50 to 69 years by 1996-97. Women who are younger, 40 to 49, they also had access to free screening, but their participation peaked at about 20% in 1998-99. Women 70 to 79 also have access but are not invited. Their participation peaked around 2002-2003 at about 30%. Both of these have since dropped, and these lower levels of participation and the higher levels in the 50 to 69-year-olds have persisted all the way to 2019. It's important to remember that the target age range for the program was extended to 74 years in 2014. At the moment, we don't have any trend data for that. The data I'm presenting comes from Victorian breast cancer treatment surveys between 1986 and 1999, and Victorian Cancer Registry staging. All breast cancer incidence and mortality in Victoria has been collected by law since 1982 and registered with the VCR. This validates these data and publishes annual Cancer in Victoria reports. The treatment surveys were carried out, 5 of them in this 13 years, and since 2006, staging data has been recorded annually. So these treatment surveys and the Victorian Cancer Registry data cover all invasive breast cancers or only early breast cancers. Early breast cancers were defined for the purposes of these surveys as operable breast cancer, and that's the same definition as used by the Early Breast Cancer Trialist Collaborative Group, and they're well described in their Lancet meta-analysis in 2005 as disease detected only in the breast, or in the case of women with lymph node positive disease, the breast and loco-regional lymph nodes, and all detected disease must be removed surgically. This is UICC, AJCC, TNM, tumor nodes metastasis, stages 1 and 2. The breast cancer treatment surveys, the data collected included breast cancer incidence and mortality trends, the staging of the breast cancer prior to surgery, the operative staging, and the final pathology staging from the operative specimens. This was the final stage assigned, except where metastases were detected by the means. The initial adjuvant endocrine, hormonal, and therapy and chemotherapy and radiotherapy that women commenced was also collected. This data slide shows the trends in breast cancer incidence, stages 1 and 2. This is potentially curable breast cancer, and breast cancer stages 3 and 4, which is advanced breast cancer and has a much higher mortality rate. Note that the breast cancer mortality, crude breast cancer mortality, we started recording in 1982, peaked in 1994, and has declined since to 2019, and this decline is 33%. The breast screen began in 1992, and you can see that prior to this, the stages 1 and 2 were on a plateau, and then there was a peak up here, and this has continued at this higher level all the way up to 2019. Stages 3 and 4 crude incidence has also increased. So the incidence of all stages has increased since 1986 through to 2019. To show a bit more detail, this is the female breast cancer crude and age standardized incidence and mortality trends from 1992 here to 2013. The age standardization is to year 2001, so these track pretty closely. Here's the age standardized mortality and the crude mortality. You can see that they peaked here in 1994. Here's the age standardized incidence and crude incidence. And here this trend line shows that the incidence of breast cancer rose quickly above this baseline trend here, peaking in 1994, and has remained high ever since. This persistent raising of the crude incidence above the trend line is overdiagnosis. This is the diagnosis of cancers that would never have presented clinically and never have needed treatment. So it leads to overtreatment. The Early Breast Cancer Trials Collaborative Group published in Lancet in 2005 the efficacy of adjuvant therapy in breast cancer, and they found that administering adjuvant chemotherapy to premenopausal women for more than 1 year and adjuvant tamoxifen to all women for more than 2 years significantly reduced their cumulative breast cancer mortality. Also, that for middle-aged women with estrogen receptor positive disease, which is the commonest type of breast cancer, the breast cancer mortality rate throughout the next 15 years will be approximately halved by 6 months of anthracycline-based chemotherapy, followed by 5 years of adjuvant tamoxifen. So when we look at the data from treatment surveys and from the registry, firstly, here is the crude mortality, which peaked here in 1994 and then declined to much lower level as the years went on. Here is the percentage of women, premenopausal women, taking up chemotherapy and the percentage of all women treated with tamoxifen. You can see that within a year of these levels of uptake, passing 50%, the mortality started to drop. Here is the screening participation overall in Victoria, and you can see that it got up to a plateau here by 1996, and that it would take at least another 5 to 7 years before we'd expect any impact on mortality. So before screening could have had an impact, the mortality drop was already 20%. And this is in accord with what Garth Welsh reported in San Antonio in 2013. As treatment becomes more effective, screening becomes less effective. So in conclusion, the adjuvant chemotherapy and endocrine therapy that Victorian women received can account for all of the breast cancer mortality decline between 1994 and 2019, a third decline in mortality. There's no evidence that mammographic screening producing any of this. This was not unexpected. 88% of breast cancer in Victoria was early and 50% potentially curable by 1995. So the window of opportunity for screening to reduce mortality had almost closed before screening began. And here are the references that these were taken from. This paper by Burton and Stevenson in JAMA Network Open. This is the hyperlink to the Victorian Cancer Registry statistics, and on the page that opens, you can select the latest cancer statistics, then Cancer in Victoria 2019, Cancer in Victoria 2020, to see all of these trends. And finally, I reviewed and summarized all of this work that was published in DI Europe in October 2010, pages 30 to 32. Thank you very much.
Thank you very much, Professor Burton. So it was a great presentation. Now the session is open for